Okay, good afternoon. It's a great pleasure and a great honor for me to be here at the Sao Paulo HIV Clinical Forum 2022, and thank you, Paulo and Amaro, for the invitation. And in the next 20 minutes, I will try to make an update of pre-exposure prophylaxis. These are my disclosures. And I'd like to start sharing with you some current epidemiological data. You can see here on the graph on the left, which were the last data published by UNAIDS, showing a slight decline in the number of new infections. However, we are still far away from the target that was proposed for year 2020. So definitely we have to work in the combination prevention. And you can see there like a puzzle, and in red, if one of the tools of this puzzle, particularly for people at really very high risk of acquiring HIV infection. When we are dealing with prevention, it's very relevant to be aware which is the population we are dealing with and which are the risk factors to acquiring HIV infection. As you can see here in Africa, definitely young women, they are really a very high risk. In our region, in America, the big green balls represent men who have sex with men. This is probably a very well-known slide for most of you and represent the 7 pivotal studies that, based on the result of these studies, PrEP as a strategy was approved. The first one, the HyPrex, showing no more than 40% of efficacy, and our region had a relevant role because many patients were enrolled in Latin America. 2 studies in Africa enrolling heterosexual men and women showing very good efficacy. 2 studies in women in Sub-Saharan Africa, PrEP and boys PrEP showing no efficacy at all. And finally, coming from Europe, the PROUD study British and the Hypergay study from France. Both of them showing very high efficacy, almost 90% efficacy. And from the beginning, it was very clear that the efficacy was associated with adherence. And you can see here, in particularly among men who had sex with men, those who had adherence, they had a very high efficacy. However, for those without efficacy, particularly, you can see women there, the boys at the PrEP, very low adherence, of course, very low efficacy. Of those 7 studies, I choose only one to share with you, the PROUD study. This study was designed and conducted by Sheena McCormack in London, and she invited more than 500 MSN living in London to participate in this real-world study. She proposed to randomize them to start TDF-FTC to 50% of them. And the other one was a control group. They didn't receive placebo. And you can see here the results, very good. 86% reduction in HIV incidence, but probably the most relevant number is here. That shows you what is to be at high risk. Almost 9% of HIV incidence in 1 year, which were the inclusion criteria of the PROUD study, to have had anal sex in the last 90 days, and to think that probably that will happen in the next 90 days. Anal sex, remember that may be receptive or insertive. Definitely, we are talking about a high-risk population. So definitely TDF and FTC are very well demonstrated tool to prevent HIV infection, but today we have been talking a lot about TAF, and definitely this less toxic drug was studied and faced FTC TAF versus TDF TAF in this huge study, enrolling almost 2,000 volunteers in each arm. And you can see here the results showing a very high efficacy of both arms and showing the no inferiority of TAF among men who have sex with men. Now coming from Europe, particularly for France, Jean-Michel Molina, he conducted this study thinking that's people who has very infrequent sexual intercourse. Do they need to take 1 pill a day? So in the same way that Pedro Can started to think many years ago that probably with 2 drugs was enough, Jean-Michel Molina, he said, well, we will protect just one sexual intercourse. And you can see here, it's very well known, it started with 2 pills of TDF-FTC together in the previous 2 to 24 hours to the sexual intercourse, the third one, 24 hours later, and the fourth and last one, 48 hours later. And you can see here the result, outstanding. You can see here, again, 86% of efficacy. When the open-label extension phase that was open was observed, you can see here, 97% of efficacy. It's unusual to have a prevention tool with such a high efficacy. But one of the questions that probably we may ask is, if one person is thinking to protect just one sexual intercourse, is it enough 4 pills? What happened if he didn't receive any pills the week before? So this sub-analysis of the Hypergate study was conducted by the group of researchers, analyzing those who had received less than 15 pills a month. And you can see, in that group, non-infection was diagnosed. So the conclusion that the PrEP on demand is the way that we call it, is even effective with infrequent sexual intercourse, with a lot of advantages, including low cost, less toxicity, but may have some disadvantages, including unscheduled sexual intercourse, and for some people, they need to have a routine. And as you can see, even coming from France, the CDC considers that on-demand PrEP is one possibility, not for people, not for women, has only been analyzed in M who has sex with men. Today, we have been talking a lot about the long-acting cabotegravir. And many years ago, the study of this injectable drug started to prevent HIV infections. And these 2 studies, the HPTN 083, among men who have sex with men and transgender women, and the 084 in women from Sub-Saharan Africa at very high risk, they show the efficacy of this intervention. Both studies had the same design. It started with 5 weeks of cabotegravir 1 pill a day in order to know which was the tolerance. And for those who had a good tolerance to oral cabotegravir, they started with 1 injection every 8 weeks, meaning about every 2 months. And you can see here, these are the results of the 083, men who had sex with men and transgender women, showing a very high efficacy of both arms. As you can see in the right, cabotegravir was not only non-inferior, but also was superior to TDF-FTC. Definitely, superiority was a challenge for a new drug, and however, cabotegravir succeeded. When the results of the 084 were analyzed, again, comparing TDF-FTC and cabotegravir, you can see here, and the good news is that both arms work. So the previous results of boys study and FAM PrEP showing no efficacy at all in women at high risk in Sub-Saharan Africa was shown here that it can work. And even in this case, again, cabotegravir was superior to TDF-FTC. This is something new and is something relevant. And very often we can see when we offer PrEP to women what may happen in the case of a pregnancy, and we are all aware that during the pregnancy there is an increased risk of acquiring HIV infection, and both drugs, FTC, TDF, or TAF, they can be used safely during the pregnancy or breastfeeding. Cabotegravir has only a conditional approving during the pregnancy. Another special population and consideration from transgender women, and if they have not had vaginoplastic surgery and are at risk of exposure from anal sex only, they can take oral TDF-FTC daily or on demand, or also cabotegravir. But if they have undergone vaginoplastic surgery, they should choose between PrEP with TDF-FTC or long-acting cabotegravir. TAF and on-demand have not been studied in transgender women. And finally, we must think that the only site of the body where we may apply cabotegravir are the buttocks, and sometimes that is not feasible among transgender women who may have silicone prosthetic. One of the problems in general when we are facing people receiving pre-exposure prophylaxis are the delayed diagnosis of the HIV infection. From the beginning, we were aware that the detection of antibodies to diagnose HIV infection using the standard methods may be delayed. When people are on cabotegravir, they even more delayed compared to FTC TDF. And we all know that it's relevant to make a prompt diagnosis in order to avoid the development of resistance, and we all know that it's good to treat the HIV acute infection as soon as possible. And so that's the reason why currently the CDC recommends for people who are on PrEP, on cabotegravir, to follow them with a sensitive RNA assay screening in order to detect very soon the incident HIV infections. One of the concerns from the beginning of PrEP was the development of resistance. However, we know that the risk of developing resistance is low. Going back again to cabotegravir, the results of the 083, remember, men who have sex with men, have already been analyzed. And including also the open label extension phase, 7 infections were diagnosed. They were breakthrough infections despite on-time doses of cabotegravir. And in 6 cases, the resistance was for integrase inhibitor was detected. From the previous study, the 7 studies I showed you at the beginning of the talk, only 0.1% was the risk of developing the mutation M184V that we all know that was created probably by FTC. However, I think that this is a relevant concept. Multiple HIV infections were averted for every case of HIV resistance when PrEP is used properly. Many years ago, actually several decades ago, the study of microbicides started. I remember very well when the International AIDS Conference, the results of the CAPRISA study were presented. CAPRISA was performed in South Africa using the gel with tenofovir. And the first result looked quite good. Then some other studies showed that the gel with tenofovir didn't protect women. However, these both studies, the ring study and aspire study, show good news. Our vaginal ring with dapivirine and NNRTR had some grade of protection in young women in Sub-Saharan Africa, showing a decrease in about 30% of the incidence. However, in the extension phase, the protection was higher, more than 50%, and unfortunately, in very young women below 20, 21 years, there was no protection. And that's good. And you can see here, last March, in South America, the local regulatory agency approved these rings to be used, and definitely it's a new way of prevention. It's a new way to empower women to protect them of HIV infection. What we have now, FTC TDF, maybe on a daily basis, maybe on demand. We have tough FTC. As I presented before, we have long-acting cabotegravir, and also the dapivirine ring. And for the future, new tools are coming. Definitely, probably, in the future, we will see implants with drugs that will duration in a long period. Some studies are now hold on because some of the studies were with islatravir, that, as you know, is causing some side effects, decrease in white blood cells. But definitely, in the future, we will have very long-acting drugs or implants that may prevent HIV infection. What is going on in the world, all around the world, with the PrEP prescription? You can see here, by the end of the last year, 2021, almost 2 million people have started. And that's not a synonym of they are still on PrEP, that almost 2 million have started. And this is the most recently published map, March 2022. And you can see here some countries such as United States, South Africa, and Kenya with a high number of people. In our region, Brazil is the only country with a high number of people on PrEP. Definitely, this map shows the iniquity of PrEP prescription and of PrEP distribution. And that was highlighted in this article published last year by Omar Sued and Pedro Can, showing that after 40 years of HIV infection in the world, that in our region, the number of people on pre-exposure prophylaxis really is very low. A few minutes ago, Richard Elliott showed something, the cascade of post-exposure prophylaxis. Let me share with you the cascade of pre-exposure prophylaxis. Look at this. This is in the United States. People who were linked to the system because they were at high risk, but they were not prescribed. And their risk in 1 year was almost 1%. Those who were prescribed but didn't use it is about 1%. Who had started but stopped, 1.28. But those who restarted PrEP really decreased. But look at this. Look at this. Those who were still on PrEP, really a very reduction in the risk of infection. This study was published a few days ago and was conducted in France. It's an 8-case control study analyzing more than 40,000 people at risk, analyzing a group who were receiving PrEP and a control group, showing no good results, no more than 60% of efficacy. And which is the message here, that adherence is really relevant. Fatigue pills may be also a problem for people who's healthy. So we have to work a lot to improve adherence. We have to work to have new tools for HIV prevention. And these are some publications for our region, 2 of them from Brazil, showing the good benefit, talking about cost effectiveness of HIV pre-exposure prophylaxis as a prevention tool. And let me finish this talk with, again, some number published but by UNAIDS. Look at this. These are the number of people who should be receiving pre-exposure prophylaxis. The red bar is the target for year 2025. The yellow one is the current situation. You can see here in our region in Latin America, difficult to see the yellow bar, probably only most of them in Brazil. This is the gap. But even in Sub-Saharan Africa, where many people are receiving, they have a big gap, or even in the high-income countries. So definitely we have to work hard in order to upscale PrEP all around the world. And which are the results of this, that we are not working perfectly in combination prevention? Look at this. This is a very interesting data comparing the results from 2010 to in this 10-year period. Look at this. This red bar is the decrease in number of deaths, and the purple one is the decrease of new infection. This is all around the world. Look in our region. We are succeeding decreasing the number of deaths, but no difference in the number of new infection. We have to improve a lot of tools of this combination prevention, including pre- and post-exposure prophylaxis. We all know that we have new targets for now it's not anymore 90-90-90, it's 95-95-95. But if you want to decrease these 1.5 million infections that are diagnosed every year, we should reach to the 95% of combination prevention. So, during this 20 minutes, we have seen that PrEP is a great tool to prevent HIV infection for people at high risk. Unfortunately, PrEP uptake has been low all around the world. We have seen that and was unequitable. We have different options, including non-daily PrEP and carbotherapy PrEP, to expand PrEP uptake, adherence, and persistence. Today, with the result of the study 084, women may also benefit from PrEP. Finally, PrEP must be affordable and must be upscaled. So thank you very much for your attention.